we start webinar, and who want come to our webinar. And today we met with Dr. Salvatore Provenzano from Istituto di Tumori, Milan, and he's speak about multidisciplinary approach in soft tissue sarcomas and hard tumors in Istituto di Tumori, Milano. And Dr. Provenzano, you can start. Okay, Misha.
We have some connection problems.
Do you hear us?
Can you hear us well?
Yeah. Yes.
We
okay.
Can hear you well.
You can start.
Okay. So thank you for your invitation. It's so nice for me to speak with all of you, all young oncologists as I am. So nice to share our consideration. I prepared some slides, but please, it's a discussion among us. So I hope we have time to discuss your ideas, your opinions, and what you're doing and what you want to build. So just to show you some data about what we have, what we're doing, and what we could do in the next future. So, of course, we start from what we're talking about. Soft tissue sarcomas, as you know, are rare diseases. The incidence in Europe is estimated between 4 and 5 cases per 100,000 persons per year. So maybe in Italy we are 60 million, maybe around 2,000 and 3,000 cases per year in the whole Italy. And they can occur at any age. Of course, we have a median at 65 years of age, but you know that these cases may onset in children as well in the very elderly. And you also know that soft tissue sarcomas body. It's one of the particularity of dealing with this kind of diseases. You see here a giant sarcoma of the abdomen, another one next to the femur, and another one in the maxillary sinus. And the other problem is that there are more than 70 different entities. Every entity is kind of variable in behavior, and every entity is different from the behavior from another one. So when you have some kind of presentation, you perform a biopsy, and the pathologist must decide which of these histotypes we are talking about. And substantially, it is something that we could say they are all the same cells, split in a slide. The possibility to state that on the left we have a uterine leiomyosarcoma because we find positivity to smooth muscle-actin, desmin, and caldesmone. On the upper right we have a malignant peripheral nerve sheath tumor because it's S100 positive, and on the right below we have a desmoid type fibromatosis because it's beta-catenin positive. And of course, you know that histopathology matters because not every diagnosis, but most of diagnoses involve a different treatment strategy. For a uterine leiomyosarcoma, for instance, you would, of course, think about surgery, at least in the localized setting, of course, and then we'll discuss about adjuvant chemotherapy. For a malignant peripheral nerve sheath tumors, you would almost think about you would propose a preoperative chemoradiation and then surgery. For a desmoid type fibromatosis, you would probably do nothing, at least at the beginning, because you know that these lesions have a possibility to shrink by themselves without any treatment. Just think that we've run kind of statistics in Italy in the past years, and we found that about 35–30% of patients have a misdiagnosis when they are biopsied in a non-referral center in Italy. So meaning that when a pathologist that it's not expert in diagnosing soft tissue sarcomas or rare tumors in general, the patient has a 1/4 of probability to receive a wrong diagnosis that could mean a wrong treatment. Same as when talking about surgeons. I mean, you know that a lot of patients arise to a referral center for a soft tissue sarcoma in general after a previous surgery, and it's often an inadequate surgery because there's no experience even in surgery in peripheral centers, because they usually diagnosed by radiology lesions in the soft tissue. They operate them without margins, intralesionally, and so on, without preoperative biopsy, because they think it's an hematoma or post-traumatic lesions or so on, and then they found it's a sarcoma. You know, the surgery, the first surgery improves survival, involves survival in soft tissue sarcoma, and if a patient receives a wrong surgery at the onset, his prognosis changes forever. And just one among all the others, the most recent, it's a study performed on the importance of referring patients with a soft tissue sarcoma to referral centers. If you read the abstract or even the full paper, it's very interesting. You find that patients that are diagnosed or operated in a referral center have relapse-free survival, local relapse-free survival, and better outcome in general than when receiving the treatments in a peripheral center. Same things for medical treatment. I mean, of course, every oncologist can give chemotherapy. It's easy. You can find the drugs, the guidelines, and so on. But not all oncologists know that there are differences among sensibility in soft tissue sarcoma. It's common even in Italy nowadays to hear oncologists that do not care about soft tissue sarcoma, that do not treat soft tissue sarcoma, often proposing epirubicin, ifosfamide to every histotype. But nowadays we know, for instance, that ifosfamide is poor active in leiomyosarcoma, so we don't offer this treatment to our patients anymore. Or we know that malignant peripheral nerve sheath tumors is sensitive to etoposide as well, which is peculiar among all types. And then we know histotypes that completely do not benefit from any chemotherapy, but instead benefit from cirrhosis, endothelioma, or others that are biliary soft part sarcomas, which is very sensitive to anti-angiogenic drugs. Or what else? There are some sarcoma, for instance, like low-grade endometrial stromal sarcoma, which is sensitive to hormonal treatment, and which can remain in control with hormonal treatment forever, for instance. So a lot of expertise is requested, and the English people, even if they're English, I mean, had some good idea sometimes. In the past years, maybe about 10 or 15 years ago, they developed a very strong guideline as regards to soft tissue sarcomas, involving not only the doctors or the physician working in hospitals, but also general practitioners, because they are those physicians where the patients go before seeing any oncologist or any surgeon. And one of the surgeons of the Royal Marsden Hospital just thought about shipping a golf ball to all general practitioners in Great Britain with a letter where he wrote, if you touch something bigger than a golf ball deep in the muscles in any of your patients at any age, please refer these patients to me, because very likely this patient is suffering from a soft tissue sarcoma. And you know that if we diagnose a soft tissue sarcoma bigger than a golf ball, I mean, very likely it's a high-grade soft tissue sarcoma that deserves a part, a wide excision surgery, sometimes chemotherapy and radiotherapy. Another article from the Spanish group, quite recent, published last year, where they decided to analyze in a very large cohort, about 12,000 sarcoma patients, how survival changes when patients are referred to reference centers and then are discussed to multidisciplinary team boards. And actually, you can see that there's quite a big improvement in local relapse-free survival. I can explain you why in a few seconds. And some improvement also in relapse, so also in distant relapse-free survival. There was a trend toward a benefit in overall survival, but the data are quite, we need a longer follow-up to state that. This happens actually not by chance, not because these patients are referred necessarily to expert people, but because when you discuss a patient in a multidisciplinary tumor board, this patient enters a virtuous cycle where every person that discussing this case shares his opinion and decides for his own competence, surgical or radiotherapist or medical, what's going to be the best treatment strategy for that patient in that therapeutical phase. So, for instance, you can see that these are the ESMO guidelines, by the way. I suggest you to read them if you didn't. That if a patient has a preplanned margin, a preplanned R1 margin, it may receive preoperative radiotherapy and maybe even chemotherapy, because there are a chance to improve local control by tumor shrinkage, and so to ameliorate the quality of surgery. So a preplanned R1 surgery may become our R0 surgery with a cytoreductive treatment given preoperatively. And so in the end, the ESMO clinical practice guidelines that were published last year in the last version were very strong in stating that all patients should be managed by expert groups, in reference centers, and that all patients should be discussed by a multidisciplinary approach, because in the end, this improves patient outcome and survival. And the European Union started to care about that. They built in the past 2 years the European Reference Network. These are networks which national healthcare providers share clinical cases from their own country patients. And they actually are built to create a network for referral centers from a lot of rare pathologies. We have the European Reference Network for Rare Cancer, which is called EURACAN. You can find the website below, so you can check later if you like. And there was the first call last year where the European Union decided the first centers in all the European countries, and the only things required for them to be designated as a reference centers were the volume of patients with the diagnosis of soft tissue sarcoma or bone sarcoma followed per year, and the number of cases that among them were discussed in a multidisciplinary team. So they know, the idea is nowadays that quality is not only the volume, but also clinical decision-making sharing. in a shared way with a multidisciplinary clinical approach. What do we do here in Istituto Nazionale Tumori? Yuri knows perfectly, of course. We meet in a weekly basis. At the moment, actually, they are running the multidisciplinary tumor boards every Thursday. And of course, we have a coordinator which collects the cases. It's me, usually. And we are then split in a core team and a site specialist team. The core team actually always involves the pathologist and the radiologist. Of course, they are fundamental because they have to discuss together because it's only by when they discuss that diagnosis quality may improve. For instance, if you have something that resembles bone, a pathologist may write, okay, it's an osteosarcoma, but a radiologist may say, no, it's not coming from the bone. So the diagnosis becomes extraskeletal osteosarcoma, which means different treatment strategy again. Of course, we have a surgeon, we have radiotherapy oncologists and medical oncologists. Together, we decide the treatment strategy in all clinical therapeutical phase. Of course, the surgeon and radiotherapist are often involved together in the treatment strategy of the localized disease, while the medical oncologist in our center quite often also in the localized setting, because we often propose adjuvant chemotherapy to all our localized patients, but also, of course, in the palliative setting. Then we have nurses, specialized nurses and secretaries in patient navigation. During our discussion, of course, if we have sarcoma arising in quite peculiar sites, for instance, a bone cancer, of course, we involve the orthopedist. If we have a gynecological cancer, we involve the gynecologist, and so on. We often involve the vascular plastic surgeon because you know that the quality of surgery is not only oncological but also functional. And you know that there are no differences in conservative surgery and demolitive surgery. Apart, the conservative surgery is performed in a reference center. And so these figures, these characters are often involved because maybe only less than 5% of our patients nowadays receive amputation instead of a conservative surgery, and maybe in 20% of, most likely it's because we shared this decision, and we do quite often preoperative chemoradiation to shrink the tumor and then improve the quality of surgery. We do a report for every case we discuss. Of course, the form is in clinical. The reason why we did such a decision, and then the to-dos. The reason is very important because when you discuss cases, I mean, it's one of the hardest things to do because very, very little patients, few patients will really, most of your patients will be very hard to refer to a guideline. So sometimes we'll have to find a mid-between, find written in clinical guidelines, then you have to motivate, for instance, why you do something that it's not exactly written in the clinical guidelines instead of another thing, for instance. In the end, you can find a lot of articles in every kind of cancer speaking about that. In the end, what a multidisciplinary meeting gives you are improved clinical outcomes, because in the end patients are receive a better care. Their survival is improved, their local relapse free survival is improved, and so on. You improve clinical appropriateness, because if you refer a patient to a team that specializes in that cancer, you avoid doing useless biopsies or useless surgery, or worse, and worsening surgeries, but you do exactly what you need to do in that therapeutic phase. In the end, you improve adherence to clinical practice guidelines, and you reduce clinical, economical, and social costs. Because, for instance, if you refer a patient immediately to a sarcoma board, he receives one surgery instead of two, as it often happens when they go to a peripheral center or to a non-reference center for sarcomas. What's beyond? We started maybe something like 11 or 12 years ago to work in a multidisciplinary way, even in networking. And those three men you can see in this slide, they are Paolo Casali, medical oncologist, Alessandro Gronchi, surgeon, and Paolo De Tos, pathologist, built the National Rare Cancer Network, which is actually a website where all colleagues from across Italy can share their case from afar, from the center with us, and we can provide them a second pathological opinion, so they have the chance to send the specimen to Dr. De Tos, and he review those samples for them, so he improves the diagnostic quality. They can share the clinical history of their patient with us. They can ask multidisciplinary question strategies for us, and we provide them a teleconsultation that in the end the objective again to refer the patient to appropriate centers when needed, for instance for surgery, and to keep patient at home when possible. For instance, if you a colleague asks you, what can I do for a advanced leiomyosarcoma patient after doxorubicin? You may answer, do gemcitabine, and of course the patient can stay at home to receive gemcitabine near home instead of coming necessary to a referral center. Again, you end up in improving clinical appropriateness, in reducing social and economical costs even for patients, because you know that traveling across Italy is quite expensive. And in general, patient care, sarcoma patient care in Italy. Our government recently found that it could be worth to support us. We've been doing this work actually for free at the moment, but they decided that probably it's quite convenient for them to support us, and so they decided last year to start funding the network. We are trying to build a new network that would has the objective of covering all new sarcoma patients in Italy every year. At the moment, just think that we share in teleconsultation about 1,000 cases per year, of new cases per year, and we see another 800 to 1,000 persons. So of new patients, of course, again. So if we have an estimated incidence of 3,000 cases per year in Italy, and we meet 2,000 of them, half directly and half from the Rare Cancer Network, it means that much like we are doing a good job, but of course we are here to improve, and so we are working on it. So it's over for me. If you have questions, I will be very, very at your disposal to answer and so on.
Thank you, Salvatore.
Salvatore, because I'm afraid that I have dimension, I can forget, question that I want you to ask. Let me first say thank you to you. It was really great presentation. So, according to your, approach in multidisciplinary team in Italy, how often do you actually have your tumor board? Is it on weekly basis, or? And my second question: do you discuss only difficult cases, or every which is really obvious? Let's say like that.
It's a very interesting question. I can tell you that we meet all together once per week because, of course, everyone. To meet more than once a week. Once a week, we have the possibility to meet the radiologist, the radiotherapist, the pathologist all together. And so, can you hear me?
I'm so sorry, it was really bad connection. Could you please repeat that? Yes, I've heard that you said that on a weekly basis, but I didn't hear about difficult cases or every cases.
Yes, so because it's hard to do more. I mean, a lot of things to do, everyone has. And so in general, we usually discuss hardest cases. Those cases where there's really a need to share all together. Of course, in the end, these patients are those that are different from those patients you can refer to clinical guidelines, are the most difficult patient, because if something was easy, we wouldn't need to discuss. But we usually discuss all most difficult cases. I have to say that in other groups, they are used to discuss all the cases. For instance, in Britain, I know that they discuss all cases.
Yeah, okay, that's clear. And another question, could you please tell me about nurse responsibility in your tumor board? Is it the same like in Switzerland and other European countries, or is it different?
Well, we started quite recently to involve nurses in the group. At the moment, they are more committed to clinical trials. So if there's something, if there are patients to be referred for clinical trials, they build the treatment plan, the diagnostic plan, and plan for these patients. While the other things, for instance, you schedule appointments and so on, are done from secretaries.
And what about social workers? Do they involve in treatment? I mean, in treatment in some decision, for example, if patient, he or she is alone, so without any relatives, how do you provide care for that kind of patient? Do you also involve social workers?
Yeah, usually those figures, those characters are involved during when we meet the patient. So in the clinic, I mean, if you admit a patient in ward or in our patient clinic, we discuss this kind of social issues, and we of course involve. We call the social worker, the physiatrics, doctor, physicians, and so on, everything that's needed to complete the treatment of the patient. What we do in the multidisciplinary tumor board is discussing what would be the best strategy to cure the patient. Sometimes, of course, when you meet a patient, it's because he's alone, he can't move, he can't travel, and so on. So you have to adapt the discussion to the patient.
Okay, thank you. And my last question, who is coordinator in your team? I mean, he's a resident, he's a doctor, he's just like, I don't know, who is you are a coordinator. I mean, that you have all the time, you have permanent coordinator in every tumor board, right? And how do you select him? So, for example, in our sarcoma board, Dr. Zinoviev, he is our coordinator, so he is a surgeon. I mean, how do we, I don't know, how do we need to choose which characteristic need to have coordinator? He's a doctor. In most cases, who is he? I'm not speaking only about sarcoma board, I'm speaking about different types of board. In most cases, who is he?
I mean, it's not, I think, a matter of specialty. Of course, A coordinator may also be a secretary or a nurse. His job is to collect cases, to select cases, to discuss. Because in our meeting, usually people, doctors who meet the patient for the first time, select the case to be discussed, then send me a message stating I want to discuss this patient and so on. And then this after discussion asks you to take on the therapeutic program for the sub-patient. So the coordinator is actually a moderator in our department.
Yeah, that's clear. Oh, so sorry. We have some technical problems. One of our participants, he can't connect with us through webinar. That's why we're calling to him.
That's why we will dance right now. Let's dance.
Как всегда, я готова вас убить.
Okay.
May I ask a question right now?
Of course. Right now you can ask question.
One moment.
One remark by Dr. Komarov.
Миш, там сколько человек смотрит?
Уважаемые коллеги, кто смотрит нас сейчас онлайн, если у вас есть какие-то вопросы, то просьба писать в чат. Мы их зададим доктору Провенцано.
Okay. We just said that if you have any kind of question, you can write it in chat. Sorry.
I want to ask you about the decision of patient selection for MDT. As I understand during this bad connection that there are only the difficult cases, but who makes the decision? Maybe the final decision to select this patient with some sarcoma. For example, it have to be outpatient, patient in outpatient department or only during the inpatient treatment. Or at what time during the treatment we decide to introduce this? In which department?
Outpatient.
Yes.
Okay. So, for example, if you have patient with comorbidities, but it's controversial topic, do we need to treat him inpatient or in an outpatient department?
Not only treat, to decide what to do.
What kind of treatment?
What kind of what during the MDT?
So who will make the final decision?
Not the final decision to introduce this patient in MDT.
Okay. So you did. I understand. So
selection of patients
is it difficult
for MDT?
or it's just general one, and we need to discuss? I think physician do that.
But who? Just organization.
We discuss patients in every therapeutic phase. So the doctor that asks the patient in charge in that moment decides, because he has some difficulty, to discuss the patient multidisciplinary. For instance, I have a metastatic patient, this metastatic GIST patient who's receiving imatinib, is in control, but one lesion is progressing. I think that it would be worth to consider to remove or to irradiate the single lesion progressing patient on treatment. To discuss the discipline and see if the surgeons or radiotherapists would do the same. They would accept to take in charge the same patient. So it's the doctor who's following the patient in that moment.
Okay. Hello, Renato. It's very good that we see you right now.
At the end,
Hello.
I succeeded.
We are happy. We are happy to hear that. Welcome.
I'm happy to.
And now you are in a frozen section duty.
No, this morning I was. Not now.
Now we are discussing the MDT in Tumori Institute in Milano, and we want.
Yeah. I have you. And the talk of Dr. Provenzano too, but I couldn't intervene So just listen.
Good reason. Okay. And I want to comment there in the report. It was a slide about the golf ball in England, and I met it with our colleagues from Birmingham, and they tell me the results of this. And Renato, you also hear the story, the end of the story, because the golf balls were sent to all the clinicians. The first line, general practitioners.
If I'm not wrong.
And this,
you should do the same in Italy.
but it doesn't.
Maybe in Russia too. Sorry. I'm here. Just moving.
This idea doesn't work in England because all the practitioners uses these samples of golf balls in the social life, not in the practice. And they have no results in these investigations, unfortunately.
Yeah, the government decided some years later to establish which centers. Yeah.
It's a basic, a good idea.
So the government, I know that the government in Great Britain decided to which centers are allowed to treat patients with sarcoma. And if a patient, if a center which is not allowed to treat a patient with a sarcoma, they do not receive a reimbursement from the government for what they pay.
Yeah.
So it's another way. Yeah, probably.
Could be a good idea even in Italy. Second operation are very frequent because of sarcoma, undetected sarcoma in local hospitals. So it would be better to avoid this kind of treatment.
And oops surgery, if you know the oops surgery in England, they already told about this. It's this word is in the vocabulary, medical vocabulary in England. It's official word. It's not only not the slang. It's official word.
Okay, we have some question in
From our residents.
Давайте. One moment, sir.
Yeah.
I suppose.
Oh, hello. My name is Nikita Shorokov. I am a medical resident here in Petrov Institute. I have.
Sorry?
I have quite.
Are you an oncologist?
Medical oncologist.
Resident in medical oncology. I have a quite specific question. Right now I have a patient with clear cell sarcoma, metastatic. So yesterday I searched a lot about this rare tumor. I realized that we don't have any standard treatments for this kind of tumor. And I want to ask you about your experience in treating these actually rare tumors. Maybe you can give me some advices, what to read, or I don't know.
Yeah.
How to treat.
Maybe you will specify.
So what makes you?
If it's necessary.
And I know for this patient, I want to specify about it because it was the first line treatment. They have no operation. They have only the one side lesion on the forearm.
Yeah.
It's resectable only by amputation.
But what about behavior of this tumor? Is it aggressive or not?
It's a really aggressive. It's local aggressive, and we have metastasis in lungs.
And
It was going very slowly from.
And
Have distant metastasis in lungs.
and only one choice is amputation at this moment, unfortunately.
And she refused.
So yes.
Yes.
Locally
Question from
metastasis, right?
Yeah.
It's a clear cell sarcoma, not very usual sarcoma. What Nikita want to ask. It's really rare
You
sarcoma.
sure it's not a melanoma?
Uncommon, because and we sure that's not melanoma. It's not a metastasis from melanoma. It's
You make a BRCA mutation and KRAS and RAS mutation.
I want to ask about Nikita.
We didn't, but we used all immunohistochemistry.
Because for different between melanoma and clear cell sarcoma, you should be perform some BRAF mutation or mutation by melanoma.
Can I help you?
Right. If you have the mutation,
Histologically, immunohistochemistry, very different. So,
but in truth, if
go on.
it is a clear cell sarcoma, what first line treatment
Well, you
should we choose? It will be the start of standard treatment like doxorubicin, or something else. What Nikita wants to say.
I wouldn't expect such.
Great, great.
Дайте сказать.
And you may propose evidences of sunitinib with sunitinib and pazopanib working. And you could try with immunotherapy if you have the chance.
Oh, I see.
So they need to check any kind of markers, such as PD-L1 or what we're talking about. You mean immunotherapy? What kind of
No
immunotherapy?
predictivity, no predictivity. So
So as far as I understand right now in PubMed or other resources, it's only clinical cases, that's
Yes,
it, yeah? So it's only reports about like clinical cases.
And
Okay.
what we should decide?
Experimental therapy.
Can we start with sunitinib in the first line? It's a very uncommon thing, I suppose.
It's hard for us to, you know, have a legal foundation.
Yeah.
No, it's soldier in right lung, and we were thinking about it. Maybe it's possible. I
So
think we
other
should refer
approach.
this patient to thoracic surgeon.
Okay,
Yes,
so
and
other
we will
approach.
do it. Maybe we'll do it after the first line of chemotherapy. Maybe MDT.
After MDT, we will decide what to do.
Yeah. And thank you for your answer. And have another question. Can I? Do you have a database of all your sarcoma patients, which you feel every day, and every new patient? And do you have long-term наблюдение, surveillance for these patients? And is it easy to access to this database?
Nikita asked how long is it lasting, your database? I mean, when did you start to have your database with all types of sarcomas? I mean, 10 years, 5 years, how long is it? And is it easy to have access to it for general physicians or physicians?
No,
from
for
other-
oncologists,
or just for
from your
oncologists,
university,
yeah.
from your institute.
Is it difficult to get access to it? I mean, if you want to, for example, initiate any kind of retrospective analysis, let's say like
so
that.
our surgeon started to run a database with all cases that were operated by them more than 10 years ago. So at the moment, they have more than 7,000 patients included with a long lifespan. As we don't have a real database, but we use the Rare Cancer Network database for a lot for retrospective studies, because you can find more than 10,000 patients there, and then coming from every town in Italy, and so we have chances to for research on that database.
Do any kind of analysis.
And how do you establish this long-term surveillance? Who calls this patient? Are they alive? So, I think.
How you check is the patient live or die?
It calls follow-up, let's say like that. How do you perform follow-up?
You call to all patients or
Sorry for our Russian, so we don't use sometimes these international words in our everyday practice. So how do you perform follow-up? And who?
For long-term follow-up,
Nurses.
we have some some regions we can check on a particular website, where you can find the date of birth and the date of death of the patient. For other cases, we call them or we meet them or we find some way. We have also the possibility to ask our carabinieri, which is an armed force in Italy, and they can check the. It's not easy. It takes a lot of time, but they can give you this kind of information.
Let me translate. Infermieri nurse in English, because guys, they don't know Italian. You said infermiere, so yeah, only me and Yuri can understand this.
Thank you very much.
Thank you very much.
Секретарь.
Информире это медсестра, разные подтипы медсестер. Окей, давай, тоже будет. Юра, что говорит?
Давайте, у кого еще?
So, do we have any additional? Let's check our chat. Maybe we have some questions in our chat.
Нет, там только написано шутки.
Okay.
We have some joke in chat, but not question.
So,
Коллеги, давайте, у кого вопрос есть, ну, который вы хотели бы задать, может, на английском не можете, то по-русски.
we can translate your questions.
Есть
guys.
какие-то вопросы?
Okay.
У нас,
Our residents
нет, у нас
don't have
патоморфолог
any
из
kind of residence,
Новгорода, да?
but we have our pathomorphologist here. Maybe she wants to make some additional comments
Because,
on it.
Salvatore, I know you have not only multidisciplinary team, but you usually is a meeting with pathologists. Can you say about this meeting?
I mean, you mean separate
how-
meeting with the pathologist,
Yes.
not a,
Yeah,
not as a part
another
of
one,
MDT.
separate meeting. We meet once per week with only with
The
pathologists.
same meeting.
And we discuss all those cases where we think that something is quite different from what it could be. For instance, where we have suspicion that clinical suspicion that a disease behaves like another, and then we can add something to the pathologist's interpretation of the diagnosis, or when we aim at something translational. For instance, if you want to ask something about this, look for AL key or look for ROS or so on, PRK, and we sit on a table with a microscope. It's very nice because we look our patient samples and we learn a lot of things, and a lot of ideas come to our mind in that occasion. It's the very aim of translational research, I think.
Нет, они сидят. Okay, I'm explain in Russian. Потому что они сидят за микроскопами, соответственно, один раз в неделю они приходят со своими случаями туда и обсуждают. Хирург прооперировал, химиотерапию поступили, дальше они садятся под микроскопом, смотрят, как бы, и там патоморфолог говорит, что вы прооперировали, думали там, что саркома, а это, допустим, там подозрение на лимфому, нам надо дополнительно его исследовать, как бы не лечите сейчас. И вот они...
So it's like MDT, but separate, but it goes like separately from MDT. So it's just like pathologist MDT, right? Something like that. Cool. But actually, we have the same in our institute. We have two types of MDT for sarcomas. One is we call it diagnostic MDT, and another one we call just general MDT.
But it's not a diagnostic MDT because it's just a diagnostic biopsy meeting.
Without rentgenologist doing.
Only with rentgenologist, only one clinician, surgeon who makes the biopsies. I am. and our pathologist. Only three specialists.
Okay.
Three type of specialists, unfortunately. I think about specialities during this. We have no medical oncologists, unfortunately, and we have no child oncologists.
During diagnostic MDT.
During diagnostic.
Do you need it if you have a separate one?
They said that we needed them.
Really? So two types of MDT during the week, it's too much for us. It was really difficult to organize only one, two. Okay.
Итак, коллеги, у кого еще вопросы есть?
No
У кого нет
questions.
вопросов?
No questions.
Только все понятно.
Everything is clear for us. Thank you so much that you're sharing your experience with us. It was really great pleasure to hear from you. Thank you, Dr. Yuri Komarov, for organization.
I have only one question for Renato. And what in Istituto di Tumori, Milan. You don't know what's happening in Roma. Do you have the same organization? Do you have the weekly meeting in MDT and another meeting with the biopsies?
Yeah. We have, yes, we have only one meeting a week, diagnostic and treatment meeting on Monday in the afternoon, in the early afternoon. And then there is also another meeting on Friday, but it's scientific research meeting at 8 o'clock in the morning, Friday. We discuss the diagnostic and clinical treatment problems connected on Monday afternoon, in which we see the biopsies. We discuss the biopsy, the radiological images, and the clinical aspect of every patient. Then for the patients who underwent surgical intervention, we discuss the treatment post surgery. But I'm more involved in the diagnostic biopsy first phase, of course. And then, yes, of course, even the evaluation necrosis post chemotherapy in osteosarcoma, for example, Ewing sarcoma, and so on.
Thank you.
We have one question from online to Renato. Can you hear me well? So which, so what kind of diagnostic procedures we can perform using, if we are talking about differential diagnostic between metastatic melanoma and clear cell sarcoma, in case if we can't detect mutation in EWSR1, and there were no rearrangements in fish. So we can't perform mutation EWSR1, and there were no rearrangements in fish. How can we do that?
It's a problem.
Why?
So
we
do
are doing
BRA. Okay. Usually they are different clinically. For example, usually it's something like a golf ball, a big mass in a leg of a young patient. Immunohistochemically, it's usually positive only both to S100, HMB45, and MARC1. Usually melanoma, big melanoma lost this kind of antibodies. Moreover, they have a clear morphology of the cytoplasm. Then you have to perform molecular biology, EWS rearrangement, and BRF. That's all we can do for a base.
So we can perform BRAF.
No more.
Just BRAF.
What your research?
So just we need to perform BRAF mutation, right?
I usually do it when all is negative.
But in case if it is melanoma without BRAF mutation, what is the next step? But in case if it is
50%.
Okay, and in case if it is not BRAF mutated melanoma, what is our next step? Sorry for that question.
You mean EWS negative for clear cell sarcoma and BRAF negative for melanoma? If there is no history of previous melanoma, for me it is a soft tissue mass, it's a clear cell sarcoma. Okay. For sure, I'm not sure, but quite sure. A soft tissue mass with BRAF negative with no EWS rearrangement, for me it's clear cell sarcoma.
Because we don't have any choose.
It's no previous history of melanoma or whatever.
We don't have any choose.
Same in Milan.
That's my point.
Okay. That's clear.
Итак,
That's my feeling.
коллеги, вопросы еще есть?
questions? No questions. Давай, говори.
Точно.
Спасибо.
Okay. Thank you, Salvatore. Thank you. Thank you all who will be together in this evening. And I think maybe we make some different meeting, maybe totally to
Next
soft tissue sarcoma or rare tumor, and invite you into this meeting.
If you're not against, of
Yes.
course. I will translate from Yuris. We are kindly want to invite you in
Alright.
case if you will have free time. Just to, you know.
But in Russian, this is strongly. Yes.
Questa persona non è
Strongly-
molto
strongly
gentile, non è gentile persona.
Okay, thank you, and see you.
Grazie mille. Grazie mille.
Bye.
Thank you very much.
Arrivederci.
Ciao.
Piacenza,
Misha.
Piacenza.
Thank you very much.
L'abbiamo fatto.